Assalamu alaikum. Today we want to discuss left PUJ obstruction with multiple lower pole stones. As you can see from the CT scan that there is moderate hydronephrosis on the left side, and it is harboring a lot of stones in the lower pole, 5 in number. This is the DTPA scan. The curve can be seen going up and remaining going towards the upper side, not coming down. And this is the report with a good functioning left side kidney with complete obstruction. As discussed previously in many videos, the left-sided procedure on the upper tract requires mobilization of the colon, and the extent of the mobilization is from the pelvic brim or the confluence of the common iliac artery, where the ureter usually crosses the artery, and up to the left crurum of the diaphragm. The mobilization of the left crurum, here you can see the ureter is visible now. The mobilization of the crurum is important because the weight of the spleen will be pulling the descending colon lower down along with it, and hence we can make a good dissection and everything. You can see the adrenal gland, the edge of the adrenal gland, and shortly afterwards the tail of the pancreas will also be visible. Care must be taken while dissecting the uppermost portion of the peritoneum, because one can injure the greater curvature of the stomach, which is popping out behind the spleen. Here you can see that we have dissected lateral to the gonal vein, and we have identified the ureter. I'm using a blunt dissection mostly, and not trying to denude the ureter. However, if there are bigger vessels, they need to be coagulated, and this is the area where the resection will be performed anyways. So we have now dissected the ureter, and this dissection of the tract continues above towards the pelvis. Care must be taken not to miss any crossing vessel, because injury at this level will be expected if there is a crossing vessel. However, in this case, congenital adynamic segment seemed to be the cause, rather than external compression by the crossing vessels. I'm not using the word aberrant vessel because it is not an aberrant vessel. It is basically a normal vessel which has divided early, leading to an abnormal course of the artery. So the segment on which we will work upon is complete now that you can see the lower pole parenchyma of the kidney. Now we dissect, I'm denuding this area just to demonstrate that yes, obstruction was there. So I denuded this portion, number one. Number two, a little bit of denudation will happen, because if we don't dissect that tissue, that may hamper the reconstruction of the segment. So you can see that there is narrowing. However, the PUJ is quite low. We can see if we resect it, it can reach easily without tension. Now, the most satisfying moment for me while I am performing a pyeloplasty, whether this is open or laparoscopic, is that when I transect the ureter, none of the urine comes out of the pelvis. That is a very satisfying feeling for me, which means that our diagnosis is correct, and the segment which is obstructed is identified. and then we make spatulation on the lateral aspect of the ureter. We clean this portion. This portion, as you can see, it is going to come down, so this portion should not be excised. However, we can see that the segment is lower down, so we can very easily excise the pelvic portion above that segment. In this case, it is quite easy because the pelvis was coming down in a funnel shape. And the other satisfying thing is that when you are cutting the pelvis, you can see that there is a thick-walled pelvis, which again is a confirmation of the diagnosis. We usually do not excise a lot of pelvis, which is called redundoplasty, but in this case, as you can see, a minimum excision is quite helpful. It seemed to me that the posterior lip, or you can see that in this case the anterior lip was a little more coming out, so in order to level both the lips, I had to excise a little more of the lip which is anteriorly located. An important thing is that segment which is coming from the lower pole. However, one should be really helpful not to overstretch the pelvis while cutting, because if you overstretch it and once you cut it, you realize that you have been on the is the removal of the stone. Laparoscopically, it was not an easy thing. These two stones, the stone number 1 and the stone number 2, were easily removed. However, this calyx was directed lower down and it was containing 3 stones. So the first stone was removed with a little ease. This is the third stone. We actually counted 5 stones on the CT, so we have to complete the count. Otherwise, we'll have to go for operative fluoroscopy. So I was talking about the 3 stones in the lower pole. The first stone was easy to remove. The second stone was a little bit more difficult than the first one. So, and this is the 5th stone. It was stuck in the calyx, in the minor calyx, and it needed mobilization. With the forceps, we could turn it round and round. However, it was not coming into the mainstream, so we had to convert our telescope into 5 millimeter so that we could go inside the calyx and then see what is going to happen. So we made it drop down and then manipulated to be in the major calyx, and then it was easily removed. The sizes of the stones were so that they were not easily removed through the calyces, through the infundibuli of the calyces. So when the 5 stones are completed, we are going to close the mouth of the glove bag so that they do not drop into the peritoneal cavity, and we will place it somewhere safe and visible where we can remove them by the end of the procedure. So we start with the repair. We can see that we have not included the posterior wall. This is a 4-0 vicryl, outside in stitch, and then in the pelvis inside out. Now you can see the lip of the lower portion is not excised. That's why without any tension the 2 segments can be approximated. So in the redundoplasty, if you excise the lower portion of the pelvis very near to the calyces, then it is usually not possible to approximate them without tension. And if you approximate them with tension, usually the PUJ is going to recur. So after securing the first knot, what we are going to do is that we are gonna pass the needle behind our anastomosis and bring it to the other side so that we can repair and do the anastomosis from the inside. In that way it will be easy. Some people do the repair of the posterior lip first and they find it easier. However, in this case I think doing the anterior lip and doing the repair from the inside will make it easy for us. The first few stitches need to be extremely fine through and through the lumens of both the ureter and the pelvis, and equally distanced and very much near to the edges, because this part of the anastomosis is really going to decide the fate of this pyeloplasty. So the initial few stitches need to be taken with extreme caution. Vascularity is the most important factor deciding the fate of the pyeloplasty or reconstruction. Dependent anastomosis is going to decide the fate. Then the anastomosis should be without tension. This is the third principle. The fourth one is the watertight anastomosis. So really it's a personal choice whether to go for interrupted suturing or continuous suturing. I personally prefer continuous suturing. However, some prefer the interrupted suturing, more so the pediatric surgeons or pediatric urologists. Results are equally good in both the situations. You can do a combination of the two, like 1 or 2 stitches need to be interrupted and the rest of the anastomosis is continuous. So it is really a personal choice and experience of the surgeon that's going to decide whether one should go for interrupted suturing or the continuous suturing. Maybe you can see that we are taking the sutures and then making them tight, and lucky enough that they are not loosening enough. Okay, reaching at the tip, this is an important step here. We have brought the suture outside the anastomosis, and now we are going to create a loop, and that loop will be outside the anastomosis, and hence we will be doing the completion of anastomosis of this side by knotting the loop. You can knot the loop, you can interlock the loop. However, knotting is good because we don't want the suture line to get loose and lose the water tightness. So if it is not watertight and there is leakage of urine, this leakage of urine is going to lead to a recurrence of the PUJ obstruction, most probably due to inflammation. So I usually take the first stitch before placing the DJ stent, because once we place a DJ stent, it may be a little difficult to place this stitch. However, it again is a personal preference. Those who want to place the DJ first and then do the stitch, they have their own points. So now we cut the tails of both the sutures, the previous one and this fresh one, because these tails may tease us. So we place a 2 millimeter alligator tip port so that it is in line with the ureter, and then we place the DJ stent, and we place this completely into the bladder so as that the tip of the DJ is visible, and then you can very easily push the coil into the pelvic calyceal system, or better if you place the coil in the upper calyx. Now the rest of the anastomosis continues. So the initial 2-3 stitches need to be extremely fine. So after water tightness, another principle is a free drainage, and for that free drainage we have placed a DJ stent. Once we are past that point, the anastomosis becomes easier and easier. However, believe me, the removal of the stones in this case were not really easy, and it really tired us. And after removal of the stones, each bit of the stitch was really difficult for us. However, if you see the results of the end results of your reconstruction, all the tiredness is gone. That is the beauty of surgery. So we have reached the tip of the ureteric anastomosis. Here we will bring the old loop through the new suture loop. Here you can see, so they are very nicely approximated. Then we are going to knot the new suture to the old loop, so that the anastomosis or the suture line does not get loose. So one of the methods of doing a knotting is making C and reverse C, and this here we are using another method which is a little more easy as compared to the making of the C. So once we are done with it, we will cut the loop, and we will continue with the suture towards the apex of the pelvis. You can see that the anastomosis is looking quite nice. The suture line is watertight. The shape of the pelvis is quite funneled. It is a dependent anastomosis. The lower edge of the anastomosis is not under tension. It has very easily reached the ureter. Care must be taken at this level not to take DJ stent in the stitch, because that will be a big problem which will become evident. Here you can see the posterior suture line. This is the anterior, this is the posterior, and now the pelvic portion. So you can see the glare from the DJ stent, which is very near to the edge. That's why it is really advisable if the stent is pushed into the upper calyx, so that it remain away from the suture line. So we are remaining with one last stitch. After that, we'll do a thorough washing of the cavity, peritoneal cavity, and remove any clots. Re-examine our anastomosis. Then we'll place a drain, and after that, we will remove the stones through one of the port sides. I hope the stones are not very large in size, and can be removed easily through the port size, a 10 millimeter port site. I don't want to increase the size of the wound. So we cut the suture, we remove the needle, and we do the wash posterior to the kidney, anterior to the kidney, over the anastomosis. You can see the anastomosis is quite beautifully placed. It is without any tension. If you want, one can re-establish the location of the descending colon by clipping these two peritoneum. However, we decided not to. So we placed the drain, and the drain should be placed in the pelvis. You can see in the offset the camera port. We removed the stones through the camera port. They were quite easily removed one by one. So the drain is placed in the pelvis. And thank you for watching. Please like, subscribe, and forward.